All right, well, without further ado, can I introduce Professor Hugh Taylor, who's going to talk to us about Indigenous eye health. Thank you, Hugh.
Thank you. I'd like to thank Auntie Matilda for her welcome to country, and also pay my respects to the elders past and present of the Ngunnawal people who've been custodians of this land for more than 2,000 generations. I'm going to talk about eye care and the work we're doing in Indigenous Australians. And I am an ophthalmologist, and one could use the rather weak pun about having us being very one-eyed focus on eye care, but I'll try not to do that. But I think that the work we're doing on eye care, although we are concentrating very much on eye care, has actually much broader implications and provides a template or some examples that can be used to link primary care with specialist services. So what works for eyes will work for ears and hearts and lungs and kidneys and cancer and so forth. So while we're talking about eye care, I want you to see it as a broader vision or a mirror, a road to provide further care. I have no financial interest to declare. We set up our small group at the University of Melbourne in 2008 to really try to see what we could do to close the gap for vision. And we've been very generously funded by a number of private foundations over the years, including a number that I listed there. Our work started in 2008 with the National Indigenous Eye Health Survey, the first national survey to try to understand what was happening in terms of eye care or vision in Aboriginal and Torres Strait Islander people. And we had 30 random sites across the whole country and looked at children 5 to 15 and adults over the age of 40. And what we found, first of all, Aboriginal and Torres Strait Islander kids have much better vision than mainstream kids. They have 5 times less poor vision than mainstream kids. So they start off way, way ahead of the game. But by the time they reach the age of 40 and above, Aboriginal and Torres Strait Islander adults had 6 times more blindness, 6 times as much blindness. So they go from being way better to way, way worse, and 3 times more low vision. And most of this was due to stuff that could be corrected. 94% of the vision loss was avoidable, was unnecessary, and a third of the people had never had an eye exam. There were 4 major causes of vision loss, and each of them we know what to do about. Cataract, we just have to do surgery. For diabetes, you need to have regular eye exams and the laser or now the intraocular injections. For refractive error, all you need to do is provide the right glasses. And for trachoma, this blinding eye infection, there was a WHO recognised strategy for the elimination that we were not following. And most of it could actually be fixed overnight. You know, if you give somebody a pair of glasses, they see right away. And if you do cataract surgery, people are going to see the next day. So this is something we could really fix. And if we could fix it, we could demonstrate the value of the pathway. I mean, treating heart disease, treating renal failure, dialysis, stuff like that are really long term. But here we've got, in eye care, we've got some immediate or overnight fixes. So we can actually prove that what we're trying to do works. And some work we did with Theo Voss and others showed that 11% of the health gap was caused by vision loss. Heart disease is number 1, diabetes, vision loss was equal with trauma and ahead of alcohol and stroke. But if we did nothing, the number of Indigenous people with vision loss would double over that 20-year period. But if we could actually provide and input what we know how to do, we could reduce that number down to less than 2,000. So I first of all just want to speak briefly about trachoma. And trachoma is this ancient blinding disease, eye infection caused by Chlamydia trachomatis that occurs where there's crowding and poor hygiene. And the key to preventing the blindness is to keep the kids' faces clean. And trachoma occurs where there's crowding and poor hygiene, and people have the infection spread from one eye to another eye, and repeated episodes of reinfection occur. And people need something like 150 to 200 episodes of infection to have enough damage to cause blindness. So chlamydial infection is totally different from other chronic infections. It's totally different from TB or leprosy or syphilis or HIV or hepatitis or anything else. It's that one infection is usually self-limited and doesn't cause much damage, but it's the cumulative damage. And because almost all the infection occurs in children, the children are being reinfected 2 or 3 times a month. And all that infection comes from the infected eye secretions. So if you keep the kids' faces clean, you stop transmission, you stop the disease. And so the picture of trachoma, clinical photographs, start off with follicles underneath the eyelid, get severe inflammation and thickening. This goes on to cause scarring in adults, and that scars contract and cause the eyelashes to turn in and rub on the eye. And most of the infection is in children, and the scarring and blindness occurs in later life. This is the global distribution of trachoma last year, and Australia is the only developed country to still have trachoma. Trachoma used to be called sandy blight, and it disappeared from our towns and cities a century ago. It disappeared from Western Europe, North America, 60 or 70 years ago. So it has been labelled by me and others as a national disgrace. And we have the strategy approved by WHO, the SAFE strategy to correct trachoma, and that's got surgery to correct the interned eyelashes, the antibiotic treatment to reduce infection, the promotion of facial cleanliness, and the environment improvement to improve hygiene. And the SAFE strategy is actually in the wrong order. It should be EFAS. It should have the environment and public health first, but EFAS isn't as good an acronym as SAFE, and that's what we're stuck with. But this has been very successful in a number of countries that have already eliminated trachoma. And so we worked with developing the health information and material to use in Australia, because the distribution of the antibiotic treatment, the azithromycin, very effective against chlamydia, but still only reduces about 95% of the infection. So it's used, if you like, as a first-line intervention or a band-aid treatment, but you've got to stop the repeated episodes of reinfection. And the houses usually start off well in these remote communities, but the problem is they are not necessarily properly maintained, and one needs to have the proper health hardware to be able to maintain healthy living. So we're really focusing on clean faces and safe bathrooms, or safe and functional washing facilities, because every child with a dirty face is a health hazard, and we've got to stop transmission by keeping the faces clean. If we could keep every kid's face clean all the time, from now to Christmas, we would eliminate trachoma. So we've worked very closely with the community to develop a whole series of health promotion activities with kits and videos and DVDs and songs and mirrors and all sorts of other entertainment, community events, including big murals, working with Melbourne Football Club, doing health promotion activities with football camps and things, a lot of different work. But the work has a broad impact on hygiene, and our 5-step card, which you see there, is about blowing your nose until it's empty, washing your hands with soap, washing your face whenever it's dirty, not sharing towels, and brushing your teeth twice a day. So that not only is this impact on trachoma, but it impacts on otitis media, on upper respiratory infection, chest infection, gastro, skin infection, and that folds on to scabies, rheumatic heart disease and kidney disease. So while there's a fine focus on trachoma, the impact is much broader. But we're also very worried about the housing and schools, about the provision of safe and functional washing facilities. And these are some washing facilities that's centred at the tap at the bottom of school, where you've got the nice basins and taps, but there's no handles on the taps, so they can't be used. Another one where there's a sink outside in the mud. And a photograph where I was last week in Freegon in South Australia with wonderful washing facilities in the school. But there's a real problem with the maintenance of the health facilities in the house. So we're working closely with trying to get housing and health working together so that they can get that targeted repair and maintenance. And if we can do that so we get safe bathrooms. Those same linkages can be used to get the prompt repair of broken doors or windows or exposed wiring. So it actually has a much broader impact on the repair and maintenance of housing overall. And with trachoma, we're actually making some good progress. We've taken the overall rate from 21% in 2008 in the children in the remote areas down to 4.5%. We've still got more work to do, and often it's the last yards are the hardest ones, but we are making some real progress. I'd like to turn briefly now to the broader view of eye health overall. And what shocked us in that national survey was the unmet need in Fitzroy, which is where I live, is the same as in Fitzroy Crossing. Now, in Fitzroy Crossing, we clearly need more provision of eye care services, optometry, ophthalmology and so forth. But at Fitzroy, the Victorian Aboriginal Health Service is less than a mile from the Royal Victorian Eye and Ear Hospital, the largest eye hospital in the Southern Hemisphere. So it's not shortage of experts that's the key, it's the access and utilisation to those health care. And we did a lot of work to look at what was happening in terms of the provision of eye care. And we ended up with the analogy the patient journey is like a leaky pipe, that there are multiple leaks or cracks where people fall out of the system as they go from having eye problems through primary care, maybe being referred to an optometrist, maybe waiting to see an ophthalmologist, sitting for years on a cataract surgery waiting list. And if we only fixed one or two leaks, the pipe is still leaking. We actually have to address each of those leaks or barriers. And so we came up with what we call our roadmap to close the gap for vision, and we found there were 42 leaks, 42 recommendations that needed to be addressed, that in 9 major areas. And it's multi-layered. It goes from national oversight, the need for statewide or jurisdictional activities, but really focusing on the regional implementation of local care models. And so at the regional level, taking a focus on a hub where one can do cataract surgery, and then building the network with the Aboriginal community-controlled health organisations, the hospital, the local providers of eye care, the optometrists and ophthalmologists, PHNs and so forth, to look at to get that collaborative network together to determine the population-based needs for eye care and look at the gap between the population-based needs and the current services. Not a beauty pageant saying, oh, well, let's just add 1 more or 3 more. See what is actually required in that region to provide proper eye care. Sort out the regional service directory and referral protocols, and look at what we can do to coordinate and case manage those people requiring care, and then to meet and review progress regularly. And we've worked out, and it's available as an online calculator for a given population. Here, this is worked out for just a population of 10,000 people. The number of people who need eye care, the number of people who needed to support that in terms of optometry visits, ophthalmology visits, and particularly on coordination and referral of the patient journey. And so this is again an online tool. If you have a population of 3,221, you can go in and see what you need to look after them. So we're very much focused on eye care pathways, but one of the major areas we're looking at is diabetes. Because people with diabetes, Aboriginal and Torres Strait Islander adults with diabetes, form 3/4 of the people who need an annual eye exam. And many of them will need referral because they have diabetic retinopathy, the changes at the back of the eye. But some of them will need referral for cataract surgery, and some of them will need a referral for glasses. So by building in place those referral pathways for cataracts or glasses, for people with diabetes, they're the same referral pathways for those people who don't have diabetes. So you're actually putting in the eye care system for the community as a whole. And a year ago, we got a new MBS item number for retinal photography, for screening photography, that has been a real game changer to help empower the communities, and there's the provision of cameras so they can do that. But still, one needs to have the health promotion to encourage people to do that. And this is just showing that pathway of care and the focus on people with diabetes. So we've worked extensively in urban, regional and remote communities to develop health promotion material about the need for frequent diabetes examination. And this again includes flip charts and videos and posters and so forth to really try to promote the need for an annual eye exam for everybody with diabetes. And just yesterday, Minister Ken Wyatt was talking about the need to really push that 715 exam to make sure that all Indigenous people are getting those preventive health checks, including those with diabetes. And this is some of the online material we've developed for grading diabetic retinopathy and recognising its needs. And overall, we're making some good progress in trying to close the gap for vision. This is the annual update we released at the end of last year, and I don't expect you to read that table, but the boxes in green have been done. Those in yellow are works in progress, and those in red are still to be done. So we've got the first step done on every one of our 42 recommendations, and 16 of them are now fully implemented. And if people were interested, that's also available on our website. And this shows the map of the regions where we've been working in at the end of last year, and already we've made much further progress, particularly in Queensland and New South Wales, and now have 41 of what we estimate 51 regions are already starting. I'm being shown I'm almost out of time and I'm almost out of slides. I think I've got 3 slides left. So not only are we getting the processes documented to show the progress we're making, but in 2016 a repeat national eye health survey showed that we'd actually halved the gap for blindness. So we'd reduced the amount of blindness from being 6 times that of mainstream down to 3 times that of mainstream. 3 times is still obscene and unacceptable, but we're actually making some really good progress. And so there's more work to do, but we are making progress. And what we need now is we need to make sure that the fund holders who hold the funds for the outreach funds are adequately resourced and those funds are fully utilised to meet the population-based need. We need to make sure that things like the Indigenous Care Team program for case management is fully funded and utilised to meet the population-based needs. We need to have these regional stakeholder groups coordinating and working regularly to follow the progress that's going. We need a national subsidised spectacle scheme and also working with health and housing and education for trachoma to make sure we have safe and functional washing facilities. So the key lessons from what we've done is the need to focus on the population-based need. You need to monitor and report what you're doing. If it's not counted, it's not done. If it's not measured, it can't be managed. And I think this provides a strategic framework. While we've been focusing on eyes, I think the lessons are much broader than that and can be used for broader areas. And one needs to look at where are we with the strategic framework for rural health as a whole. So in summary, fixing eye health is clearly feasible, it's evidence-based, and we're actually making some really good progress. Thank you very much.